speaks volume to the fact that we're committed. We're committed to equity work. We're going to continue with equity work, and just thank you all very much. I'm going to go ahead and share my screen because I would like to begin with just talking a little bit about CIBHS, a little bit about COE-BT, and then let's get into the wonderful meat of this conversation with our wonderful panelists. So CIBHS, we are a statewide training and technical assistance center. We have staff and a group of core consultants that have backgrounds. We have behavioral health clinicians and practitioners. We have a high number of community integration specialists who have lived experience. And then I would say that really everybody at CIBHS has a strong background in trying to really build organizational effectiveness and improve quality of services in behavioral health. We have 4 kind of key areas that our expert-led trainings, workshops, and conferences focus on. One, we are dedicated and committed to being able to improve the clinical work of behavioral health clinicians across California. So we do a very significant amount of clinical practice improvement trainings, workshops, and conferences. We are recognized that all of us are impacted right now by a high number of statewide policies that are impacting the healthcare and behavioral healthcare field. And often to be able to achieve the vision of those statewide policies, provider organizations are needing some support around implementation on the ground level. So we provide that sort of support as well. Health equity system transformation, the project you'll learn about today, is a really great example of the way that we try to do health equity system transformation with a strong emphasis on pillars in our organization, which are co-design and co-production to support equity. And the co-design and co-production is with the community. And then finally, we have a number of courses that support leadership development. So COE-BT, Cultivating Outcomes through Equity and Behavioral Telehealth. COE-BT was our very kind of little name that we came up with since our name was so long. It was a learning collaborative, and we too were funded by the California Healthcare Foundation. The collaborative started in 2022, about midway through 2022, and it went through the end of 2023. However, the planning started at the end of 2021, and that really influenced the focus of the collaborative. We had 12 wonderful participating behavioral health providers as part of the collaborative, and each one of them had a community agency as a partner that they chose. The behavioral health providers represented counties as well as community-based organizations and FQHCs. As I said, we started our planning at the end of 2021, really kind of still just coming out of COVID. And so there was a significant focus on telehealth and ensuring that we improve the quality of telehealth and ensuring that there is equity in telehealth. And so that was the initial goal, initial aim, really, vision of this collaborative. But as we move forward, it wasn't that telehealth became less important, but there was real recognition that to address structural barriers to effective telehealth, you can't see telehealth as a silo. You have to really be able to work and address racism across the entire organization. And so we made that shift. We made it again in collaboration with the providers and community agencies that were part of the collaborative. We evolved 3 different core levers of change in order to be able to address racism. The first one, which Ebony Chambers is going to talk a little bit more about, was equity-grounded behavioral health practice coaching. And that practice coaching was really critical to being able to help prepare behavioral health providers to be able to be in partnership with community agencies and have mutual learning between the two. Community partnerships, the community agencies, they often fill gaps that behavioral health providers experience, especially when they're trying to really address all of the needs of marginalized communities. And so Kalita Gardner is going to be speaking a little bit more about community partnerships, the experiences and the learning that they had as they partnered with a substance use disorder organization in Southern California as part of this project. And finally, the strategic use of behavioral health outcome measures. And so there was a desire to really think about how do we move away from just symptom-focused measures or process-focused measures and try to implement recovery-oriented measures. And why did we do that? Because our planning included a number of focus groups and key informant interviews with clients. And that's what clients wanted. They wanted behavioral health providers to get support to be able to use recovery-oriented measures strategically within their organization. And so those were the levers. And what I'm going to do is take us off. There, good, it worked. Take us off of the slide so that we can actually move into conversation. And so, Ebony, I'm so happy that you are here with us today. I always learn so much from you. And so I was hoping that you would be able to kick us off. And would you be able to describe your role in coaching behavioral health providers and sort of the type of coaching that you offered?
Yeah, thanks, Jennifer. And big thank you to you, CSF, for inviting us to talk about this work. It was a really impactful journey. And my role as coach was to really support provider organizations, behavioral health provider organizations, to embed culturally responsive and trauma-informed and specifically community-driven practices into their work. And really designed to meet providers where they were, whether they were really just starting their equity journey or already really implementing some really good practices, but just needing that deeper alignment and stronger community partnership. So the coaching really helped to focus on a lot of self-reflection, but also systems change. There was a lot of mindset shifts, as Jennifer was sharing about the pandemic and the need for us to do a lot of shifting in our approaches. I think a lot of organizations were really struggling with that, and the community was definitely impacted. And as someone with lived experience, kind of having to knowing what it's like to navigate those systems without the pandemic, this was a really passion point for me also to really be involved to support with the coaching sessions. And so it really ranged from opportunities for the one-on-one coaching with the provider organizations, but there were times when we also included our community partners into those coaching sessions because that also gave a really strong grounding for the opportunity for more collaboration and also a recognition that technical training just wasn't enough. That coach, the collaborative had opportunities for learning, lots of amazing opportunities for them to learn together and deepen that understanding. But coaching offered the opportunity for the self-reflection and exploring questions that hopefully structured conversations for a more maybe lasting and impactful change.
Wonderful, Ebony. So, Ebony, I know that many training and technical assistance projects integrate office hours into the overall design. You know, it's a way to, I think, be able to support some of that coaching. But the coaching that was done in COE-BT was different because it was a team of behavioral health providers from a singular organization who really established a core relationship with their coach over the course of the year and a half. And so, can you talk a little bit more about some of the benefits that you saw? You talked about self-reflection, maybe expanding on that, in the behavioral health providers that you worked with, as well as the community agencies.
Yeah. Relationship building, lots of relationship building over the course of the time that we were all working together. Being able to meet with them monthly and even in between through lots of just opportunities to engage gave us a chance to unpack some of the real world challenges that were coming up. So as they were experiencing challenges, the coaching gave us an opportunity to talk about it real time, even some of the barriers that they were experiencing in trying to bridge that partnership. What I know and what I think our communities know is that there's a lack of trust, and we have to be honest about some of the harms that have been caused in community. And our providers sometimes had perpetuated that harm, or even were currently perpetuating those harms. And so it was really important in those coaching sessions for them to be able to bridge the gap between their intent and their impact, and be able to name where they may have made some missteps with the providers and with the communities they were engaging in so that they could really work to build the trust, not just within our coaching session, but with their community members.
Wonderful. Um, we talked about this coaching, Ebony, as really a lever to be able to help build that foundation of these partnerships between providers and community agencies, which we know are not easy. And
Yeah.
so, what do you think the coaching did specifically that really promoted healthy relationships between providers and community agencies?
That's a good question. I think the largest outcome that I was able to see in the coaching experience was the ability to redress some of the power imbalances that exist between provider organizations and community organizations, and then supporting our provider organizations to really shift from this service provider mindset to a co-creator mindset, and that they are co-creating and designing programs with the community, and not just in mind, but the community is leading and driving that process every step of the way, from design to implementation to evaluation. They were intended to be in close partnership with the provider, with the community, to help strengthen and rethink what that definition of partnership looked like, so that they were leaning into true shared leadership. So I think, we saw a lot more active listening, a lot more reflection on, oh, that probably wasn't the right direction, and let's come back together and apologize and make amends and figure out what does our stronger, resilient partnership look like moving forward. And so I think that was one of the biggest takeaways that was helpful for that community partnership to develop.
Yeah, and I could see where that process, you know, healing, um,
Yeah.
how critical it is to be able to have a facilitator of that process. And it sounds like as a coach, you really facilitated a lot of those processes.
Yeah. Yeah, there was. Healing is the perfect word, Jennifer. And just thinking about one, sometimes the lack of trust, and then the past harms, and then being able to have someone there that's outside of the both the organization and community to bridge that, and hold hard conversations. And in all honesty, there was tears, right? Like, these
Mhm.
communities are invested. They want to see their communities thrive. They deserve to see their communities thrive, and provider organizations have the absolute intention to do so. And at the same time, we don't always get it right, and that's okay. It's just, how do we then deeply listen and get back on track, and that has to be the foundation before any of the other work can happen.
Mhm. Thank you so much, Ebony. I feel like there's a kind of much clearer idea of like why coaching is such a critical lever of change and why really equity grounded coaching.
Mhm.
Kalita, I think that you had some questions for Ebony that you were interested in having some time to ask.
Yes, thank you so much, Jennifer. And
Mhm.
Ebony, I just love your frame of thought, and I would really like to lean in and get your wisdom around helping an organization such as mine that is looking to build a wellness center, but we have multiple cultures. So how can we serve the multiple cultures in an authentic way?
Such another good question, Kalita. I go back always to co-design and co-production. We say in our lived experience communities, nothing about us without us. And that just means that, we're no longer creating systems and pathways without the communities that are impacted by those. And so when we're thinking about the concept of wellness, we know, especially in culturally diverse communities, how that's defined looks completely different for those communities. And so when I think about this opportunity for shared shared leadership, even having a council of community members from those diverse representative of the diverse communities be available. And if possible, I always chime in stipend, right? Like if we're asking for the labor of our community members, that we also compensate them for their time and their expertise. And so really just providing a space where they can come together and share, this is what I know to be true for myself or the community that I'm a part of, or they're tasked with even going back to their communities and asking questions so that they're not just speaking on behalf, because that can be a really significant burden of saying, like, I'm speaking on behalf of the Black community. I can't, I won't. We're not a monolith, right? And so just really taking the time to really honor each unique community's diversity and thoughts around what their wellness journey can look like, and then allowing that to shape the wellness program within the work that you're doing. I am excited about it, though, Kalita. I can't wait to hear more.
So are we. So are we. So I'm curious if you could elaborate on equity grounded practices that we could perhaps utilize.
Yeah. So I believe code production is a part of our equity grounded practices, right? Because that also requires us to do a lot of deep listening in to our communities. And then, of course, as we also know, that all communities are not served well. And there's a lot of disparities and gaps in care and how one accesses their mental health and behavioral health or wellness journeys. And so when I think about it from an equity grounded approach, I would want to know what my community's data is. And I know Samantha's going to talk a little bit about data, so I won't croach into her into the amazing work that she's doing. But I do think that, we can't target for change something we don't understand. I always quote Dr. Richie Rubio because he has a great way of really helping us to really understand the why behind how data can really drive impactful work. And so when I also think about where I might go with equity grounded work in this in contributing to a wellness initiative, I want to know where's our starting point, and what is how is the community experiencing it? What are the gaps to access to care, and also even as they're managing through and navigating through services, what's their quality of care, and are they getting better? And so that gives us that data point, and then hearing from community what strategies they'd like for us to start implementing.
That's really, really good insight. So I really am curious, because this is all new to us. What would you say is an equity grounded wellness center?
These are surprise questions, y'all. I am not really
Everything's the hard ones. Kalita was just like waiting to ask this one.
This is great. Okay, give me the question one more time. An equity grounded wellness center?
Yes.
Oh, an equity grounded wellness center. I'll say what an equity grounded wellness center would be like for me, because I'm going to speak from myself and what I would want to see, because I have navigated these systems, and they're not doing what they need to be doing. They're not giving what they need to give. So I'll just say that. So for an equity grounded wellness center for me would be one that I could access easily in my community, that I could that's within driving distance, that offers a blend of not just in-person supports, but also telehealth opportunities, that is reflective of the community that looks like me, not just in my Black identity, but in my queer identity and the many other identities that I hold, and that they're also trained in culturally responsive practices. I want the community to look like me, but I also want them to understand the systemic inequities and the structural barriers that folks like me continue to face. And that there's folks that are there not just with clinical backgrounds, but with lived experiences that can offer support and resources and opportunities to provide system navigation, as well as just coming in and being able to take yoga or mindful meditation. And so that my wellness journey doesn't just look like these one-to-one therapeutic interactions, but that they're thinking about my whole self, my body, my mind, and my spirit.
Awesome. Awesome. Thank you so much, Ebony. That's great stuff.
We only put you on the spot, Ebony, because we know we love your answers.
Ooh, I was sweating, y'all. I was sweating. I'm like, oh my goodness, she is hitting me with
But you
these
described the
questions.
wellness center I would love to go to. I bet everybody on this call would love to go to that wellness center.
Yeah.
So thank you.
Yeah.
Now we've got our model. Kalita, Second Baptist Church, and you personally were just really critical to this learning collaborative. You brought so much teaching and so much grace to the collaborative. And so I was wondering if you would be able to talk a little bit first about just helping our participants understand what was your faith-based organization's role in the collaborative.
So thank you so much. I'm not as good as Ebony, but I'll do my best. So Second Baptist Church really values that everyone has a holistic approach to our wellness. Oftentimes churches only focus on the spiritual, but as Ebony said, it's about your mind and your body. And we really wanted to provide our congregants an opportunity to know that it's okay not to be okay and to get the help that they need in a culturally sensitive way. So we partnered with a local center, the New Beginning Center, and surveyed our congregation to understand their needs, much like what Ebony said. We did follow the playbook and found that our congregation really is interested in getting additional help. Oftentimes, members will come to the church before they'll go to a therapist for help. And they rely on the church to help them through some very difficult situations. But our leaders are not necessarily trained in how to address substance abuse in an effective way. From a spiritual perspective, we can support them, but we knew that we were in need of some additional support. So we were really glad to participate in the collaborative.
Thanks so much, Kalita.
Mhm.
I know that churches have lay pastor counselors, that there's so much support to be able to address mental health and well-being.
Mhm.
But what was it that you were seeing in your church? Like, what were some of the behavioral health issues that were coming up that you recognize we need to partner with a substance use and mental health organization in order to be able to address some of these issues? And this part wasn't in the questions ahead of time, but what do you think really stops members of your congregation from going to a behavioral health provider organization that's not connected with a community agency?
Mm. So I think that the issues that we started seeing coming out of COVID, quite honestly, were multi-layered. We saw young people who were just discouraged. They didn't have young Black young men were not motivated, didn't have a lot of opportunities for gainful employment in Orange County, where it's extremely expensive to live on your own. And so we saw these young people staying at home and then their parents becoming frustrated. They've had spent money, getting them through college, and yet they're at home, playing games and not really asserting themselves. So we saw an uptick in that. Then we also saw broken relationships and the attempts to cover up the issues, the root cause of the issues, where substance abuse loomed and grew. And when couples decided to get a divorce, there were spiritual questions around divorce, but also some very practical issues were starting to surface around domestic violence. So we knew that we needed to partner with an organization that is culturally sensitive, because that is one of the things that hindered many of our members from pursuing therapy with other organizations that were not related or not connected to the community. Trust is really, really big, as Ebony said earlier, and it's lacking when it comes to going to a therapist where you're going to reveal your personal, deepest, dark family secrets. So we knew we needed to work with someone who was culturally sensitive and also to educate our congregants on how to get the most out of those sessions. What do you need to bring of yourself, if you will, to get the truest impact from the benefits from having gone to a center? So we partnered with them to make sure that that experience and handoff was a gentle one and an informed one.
So, Kalita, you're talking with 125 healthcare providers and behavioral healthcare providers. What advice would you give them? You talked in order to ensure that their organizations are ones that, and let's be real specific, that your congregants would want to go to when experiencing some of the issues that you talked about. And you talked already about trust. And this ability to build trust is a cornerstone to ensuring that individuals who need services actually go and get those services. So you can either expand a little bit on that, or do you think that there are other sort of lessons learned that you'd like to pass on to our participants?
So I would say, especially coming from the church environment, that our faith is extremely important to us. And so I know that there have been times when people were questioned about praying out loud and talking to God regularly, right? And just understand if you're going to be culturally sensitive to the faith-based organization, that prayer is critical in our survival and our healing process. I would even say that there's been studies around using your faith for healing practices and that advancing that process very well. I would also say that there's a lot of shame and trauma in the Black community where people have had to weather racism, had to weather judgmental attitudes in the workplace. And so to come to a therapist takes a lot of courage. And to affirm that courage and partner with that member who is looking for help, not just as an individual, but for their entire family and community. We're big on community, and we heal in community as well. So recognize that the community is going to play a significant part in our healthy journey towards healing. And don't ignore that community because they can sabotage the process if they're not brought in.
Yeah, it's interesting listening to you, Kalita. I could see where this partnership between the Second Baptist Church and New Beginnings was so critical because unfortunately, often our provider structures are set up where we're set up to see people individually. We're not set up to see a whole community, I mean, and sometimes we, if it's a child and family serving organization, sometimes we'd be able to see the family, but not necessarily the whole community or who the client is defining as their community.
Mm-hmm.
So it sounds like this partnership really allowed there to be that extension of the way that New Beginnings worked.
Absolutely.
That probably really allowed for much greater access.
Yeah. I do recall that we had several members who were really concerned about the impacts of the children of an individual who was suffering from substance abuse and felt powerless in being able to rally around the child, rally around the family, the spouse of the abuser. And New Beginnings was able to provide some tools around helping and being a safe place for the children as well as the family members.
That's wonderful.
Yeah.
My final question for you, Kalita. as we think again about some of the learning that might help our participants, what was in place that really built the trust between your two organizations? You know, how did, you know, you didn't, even though New Beginnings was right down the street from you, you didn't know they existed. And suddenly they came and knocked on your door. And so what did they do that helped build the trust? And then, you know, flip side, what did Second Baptist do that helped build the trust with the provider?
I would say it was really concentrating on building relationship. So, oftentimes when someone is seeking a therapist or a center for some type of assistance and they don't see another Black face, the trust is really hard to build. And it can be built as long as they're culturally sensitive. You don't have to be Black to be culturally sensitive to the Black community. But New Beginnings was led by an individual who went to UCI and visited Second Baptist Church while he was in college, graduated later on, and then came back and talked to us about the telehealth survey. So he had some knowledge about the community and he really built relationships around that. Also, I would say that the anonymity that New Beginnings offered, even though it's close and accessible to our members, everyone didn't know who was attending those sessions, right? So they were able to be transparent and their authentic selves in their sessions to get that healing that they needed in a group setting, but away from the church, where perhaps shame might have raised its ugly head, right? So we really worked hard to ensure that everyone knew where New Beginnings was able to see their schedule and participate without being tethered to the church to have to report back. And then we also worked to provide scholarships for people who were not able to pay for services, but were in need of them to kind of onboard them through the process of getting serious help.
Wonderful. I mean, like listening to you, it makes me so aware of the trust in the relationship building is critical, and there are structural changes that had to be made really on both sides,
Mhm.
you know, New Beginnings and the church in order to be able to really support access for your congregants. That's wonderful.
Yeah.
Lita, thank you so much.
Thank
Just
you.
really wonderful to hear from you. I am going to shift us to our third lever of change and talk a bit with Dr. Spangler. I know Sam well. I love calling her Dr. Spangler.
No one calls me that.
I know, except me. So, Dr. Spangler, can you tell us a little bit about, you know, how it was that the collaborative, how did we decide to focus on recovery-oriented measures for evaluating the work? I know I talked earlier about the fact that, you know, we got that feedback in our focus groups, and our key informer interviews, but I think it was bigger than that. So do you want to talk a little bit about that?
Yeah, thank you. So I was the evaluator for the COE-BT collaborative, and I got to have a fairly unique and extremely valuable experience through COE-BT, which is that as the evaluator, I also got to participate in the design of the collaborative, which is just really, really uncommon. But so as we were designing the collaborative, and like Jen mentioned, the collaborative itself started in 2022, but the design process started in detail in late 2021, but the stakeholder process and the co-production process of it started even before that. So we did a long and involved process where we talked to representatives of state and local governments. We talked to behavioral health associations and advocacy organizations. We talked to health plans and direct service providers. And really, most importantly, we talked to people and families with lived experiences with behavioral health conditions who came from diverse backgrounds and across the state of California. And so part of what we asked them during these conversations was for providers and associations and regulators, we asked them what they currently measure and what they wanted to measure. But then at the same time, we asked the people and families with lived experiences what they wanted to get out of behavioral health services. And what we learned was, probably not shocking, but it was enlightening. So pretty consistently, our like system stakeholders, so providers and regulators, told us that they were measuring processes for how behavioral health services were provided. And sometimes they were measuring improvement in symptoms or quality of services. But very overwhelmingly, when we talked to people with lived experience, they told us that what they want, the reason they went to behavioral health services and what they wanted to get out of them was to improve their overall quality of life. And so we wanted to, as part of our design, to include an emphasis on actually measuring the things that reflect participants' ability to build a life that's meaningful to them and enjoyable, so that we don't just focus on the challenges they're experiencing or the diagnosis they may or may not have received, but their overall health and well-being.
That's wonderful, Sam. Sorry, I'm a little distracted because of my little Brady square is flashing, and so hopefully it's not being seen to all of you. So, Sam, one of the tools that we used, really recovery-oriented tool, was the flourishing scale. And so, can you talk a little bit about the scale? What made it unique? Why did we choose it? And what was its impact on our collaborative attendees?
Yeah, absolutely. So one of the other things that COE-BT did that you don't always see is we were led by a core design team, and that core design team was selected with to make sure that it included representation of diverse personal and professional experiences. And so one of our core design team members, Karis Myrick, who many of you may know and have hopefully had the privilege to work with, was the one who recommended the flourishing scale to us. The flourishing scale is an 8-item self-reported measure that was developed by Dr. Ed Diener in the early 2000s. And on the scale, participants rate the extent to which they feel like they have supportive relationships, that they have meaning and purpose in their lives, that they have optimism in the future, amongst a few other items. But so when we were so we liked it immediately, right? It seemed to fit with what we had heard from the people we had talked to about something that they would find valuable as a measurement tool. But we also wanted to make sure that the tool had a strong research base, so that it was psychometrically validated. So the results that we got out of the scale would be reliable and usable to the providers when they collected the data. But we also wanted to use something that wasn't just, studied with college students. So one of the things that really made the flourishing scale appealing is that it had been used in multiple countries, in multiple cultures, in multiple languages. And it also had been previously used by people with significant mental health challenges. So that encouraged us that it would be feasible for the organizations that we were going to work with. The scale is available in 17 languages, in addition to English, including both Spanish and Korean, which were 2 common languages used by our participating providers. So those are all the things that sort of made us feel like it was a good tool for us to use. You want me to go on, or?
You sound like you're midway. I would love for you to expand, and also want to ask you, as the evaluator, you and your team did really incredible both midpoint and endpoint interviews with all of our providers. And so as you had those, pretty intimate discussions with them, what were some of the things that they talked about learning by using the flourishing tool?
Yeah, thank you for asking that. And actually, I'm going to start even before the midpoint interview, and I'm going to start with what happened when we went out and started and introduced the tool to our participating teams. And, a lot of you here are work in behavioral health organizations. And like Jen mentioned at the beginning of the call, there are a lot of changes happening in behavioral health right now, and there have been for many, many years. So as an evaluator, I am accustomed to, when I go in and try to introduce a new data collection tool or a new process, the immediate feeling of overwhelm. And I don't know if we can do this. We've already got so much on our plates. But we were really pleasantly surprised by how enthusiastic our providers were and how enthusiastically they embraced the flourishing scale. The providers, we just really didn't get any of that like pushback at all. They were very encouraged by the idea that they really could measure quality of life and things that were meaningful to their participants. I think for a lot of our providers, that's felt like a thing that's very difficult to do. And so this gave them, a fairly clear and straightforward pathway to that. COE-BT's goal was that providers would pilot the flourishing scale. So we didn't want to give really rigid implementation requirements. We didn't set, you have to use it with this number of people or with this number of frequency or even in this manner. We sort of encourage them to try to build it into their organizational practices and to really just to try it and see how it worked and come back to us with feedback. We really wanted to hear from them both how it was for them as providers and how their communities and their clients were responding to it. And that, I think, is where things got really cool for us. So 9 of our participating teams were able to pilot the tool. The ones that weren't largely faced sort of either workforce shortages, which we know are a problem, or organizational, like structural barriers around getting approval to do new data collection. But the tool was really, really well received by the direct service providers themselves. So not just the organizations, but actually the people who are tasked with administering the tool. Providers told us that it was fairly easy to use. And they actually expressed some surprise as well that it led to meaningful conversations with the people they serve. One of the things, often data doesn't get fully integrated into clinical practice. It feels like a thing you have to do on the side, right? Because your regulator told you have to. And one of the things we heard overwhelmingly here was that if providers did that, they were missing a huge opportunity to stimulate conversation with the people that they were serving. Our providers told us that they sometimes learned surprising things from their clients' responses to the flourishing scale, both about things that, strengths they didn't know they had and challenges they didn't know they were experiencing. And so sometimes they even used the tool to help shape the treatment goals in their work directly with the people that we're serving. We also got really encouraging feedback about the cultural appropriateness of the tool and the ability to use it with diverse populations. One of our participating teams, the Native American Health Center, actually did a really comprehensive process with their tribal advisors and their community and just got really, really encouraging feedback. That not just people said this wouldn't be a problem, but they said, actually, this is exactly what we want. So we were really encouraged by that. Just to throw some data at you, over the course of the project, our teams actually collected nearly 1,000 different flourishing scales over the course of time. So, which really with the implementation period of this was about 6 months time. And so it just goes to show that even with all of the different challenges they were facing, they found it valuable. They were able to use it. And we're hopeful that a number of them are continuing to use it after the collaborative.
Mm-hmm. Thanks so much, Sam. Great overview of just that tool and how recovery-oriented measures can really be just levers for change, particularly as you're really trying to think about how are you bringing together work with outcomes and advancing equity in your organizations. So I was wondering, Marie, if we have had any questions come in. That's the end of our formal interviews, but we can spend some time on if there are any questions from participants.
We don't have any questions in the chat, so I encourage folks, if you do have a question, feel free to either raise your hand or put the question in the chat if you don't want to unmute yourself. But now is a great opportunity for you to ask questions of this group.
No questions are also fine. We do always like for people to make certain that they have time in that lunch hour for themselves. And so if there are questions, we would love to be able to respond and kind of answer your questions, but it's fine if there's no questions. Thank you, Tanya. So we have a question that's coming in from Bruce and Bruce Rowe. I hope I pronounced that correctly. How do you have difficult conversations with people in power who are adverse to changing the system or losing their own power? Anybody like to take that one?
That is such a good question, Bruce. And I think one, I always reflect on two ways or two areas that are really important when we're thinking about transformation and change. And that's that someone, when we're thinking about change, someone has to have not just a skill, but they also have to have the will. So both of those really are important. I always say like will and skill, right? I think Dr. Kenneth Hardy talks about this a lot in his work, who does a lot of racial equity work and conversations. And so coaching can help us kind of shift our will, right, along with like things like motivational interviewing and a lot of things just in regards to starting there. But I do think, right, when someone's worried about losing their power, there's a risk of like, right, losing control. And I think that it's important to recognize that. And so I encourage when we're thinking about having these difficult conversations with folks in power is, one, coaching is really helpful to that, but meeting them where they're at and what they're going to lose, but also being able to highlight what they will gain and what the community will gain. And so I'm always thinking about how do I assume positive intention, even when sometimes it's really hard for me to do that, and depending on the audience. And so just thinking about how do I create a space that allows for them to examine and explore what the community is missing, and how giving up and some of that power actually brings it back to the community for them to thrive. And if we start with what do we hope to see, I hope, right, when we're asking these types of questions, that everyone wants to see a community that's healthy and thriving. And that requires that we all give something to that. And that includes power. So really just meeting where they're at, examining their will and their skill. And then, I believe in staying persistent, and, continuing with conversations, even when that person might not engage right away or experience a lot of barriers and resistance. Because I think if we anticipate that, sometimes it's not as frustrating, Bruce, if that makes sense, at least for me, because I recognize along this journey just how difficult changing mindsets is. I don't know if others have thoughts.
I'm going to say, I will add to that, just, Ebony mentioned showing them what they can gain. And of course, I'm the data person, so I'm going to talk about, so I'm going to say, use data to do that. Use data to show where there's need, to show that where there's potential for gain and improvement, and to show where there's evidence that certain strategies work. But also in particular, when you're thinking about using data from an equity perspective, make sure you're not just relying on numbers, and really focus on storytelling, community experiences, and the sort of qualitative value of what you're trying, the change you're trying to bring about.
Wonderful responses. Another question came in, another really great question. How do you engage historically unengaged patients? So Vivian, thank you so much for that question. And I think this can apply not only to clients or patients, but also, Cleta, be interested in hearing from you as well. I know that you have a really large congregation, but I know that there are probably different steps that you've taken to make certain that you're really engaging folks who may not have come through your doors or who wouldn't come through your doors.
Right, right. So within our church, we had a series of sermons and resources made available. We went through a really traumatic situation. I'll tell you, the end was he survived. It all worked out well, but our pastor was attacked in front of his home and
Sorry.
stabbed 7 times. And like I said, he's fine. He's thriving, and we're so grateful for that. But it really rocked the core of our church, and it elevated the need for everybody to get some healing. So we provided counseling, virtual counseling for anybody and everyone who wanted to attend. And then we also had a series of talks around mental health and the importance of mental health, and just really remove the stigma associated with mental health and access to mental health. So that was really the triggering point for us to travel down this path. And then we participated in a collective of churches that really wanted to work with the community at large to provide resources to the community that could help us to thrive. And we started with a survey, surveying the community. We found that 90% of those who we surveyed, which was the first ever, a survey created by Blacks, delivered to Blacks, analyzed by Blacks in Orange County, we found that the number one need was access to mental health care services that are culturally sensitive. But people didn't know how to access those services. Even if their providers provided it free of charge, they didn't know about it. So we went on this campaign to educate people on the benefits that they have with their providers, their insurance providers, but also started providing peer support specialists who are available to walk alongside people no matter where they are. If they're in Orange County, we're going to provide that support. And it's helping the community to really get in touch with the needs that they've had, articulating their needs, and then finding spaces for them to embrace those needs and basically meet the needs.
Thank you so much, Fiona. Thank you so much, Cleta. Sorry, we have two final questions that we'll be able to get to, and both are pretty powerful. So Fiona asked, when the system is government-based behavioral health services, equity and access in our area is a huge barrier. System change often seems unattainable. Any thoughts from anybody about how to get the system to move with a focus on treatment and outcomes? I just want to make certain we also have time for Natasha.
I suppose I can take that to start. I'll try to be really quick here. Generally speaking, the system moves slowly, but think about the things that are driving the system itself, right? The people who are making the overall decision. And so, again, I encourage use of data, but really they're from a perspective of showing why it is beneficial from not just from an intrinsic perspective to be equitable and to increase access, but to show how that increases the value of the services you're providing, decreases the costs of other things that are happening in the community that the system has has to bear because of lack of access and lack of equity. So I would say focus on how the system gains from improving access and equity.
Thanks so much, Samantha. And we'll finish up with Natasha. Natasha had a personal experience with a dermatologist, and she went to this dermatologist to be able to get help with hair loss due to menopause. And the dermatologist told her that due to being a Black woman who has worn braids at any point in her life, she should just cut her locks and hope their hair grows back. So she felt like she had no power to do anything except request a new dermatologist. Any suggestions on how she could have handled that situation?
I will take this as Natasha, your story. I'm so sorry that happened to you, and it deeply resonates because I was misdiagnosed with a serious health condition because I was told that my skin was the way it was because I was Black, and it was not. It was actually a more serious health condition. So. Um, I definitely encourage reporting. I think that oftentimes we have these adverse experiences and we switch providers because we're just exhausted, but nothing changes when we don't report the folks that have caused us significant harm. And so I encourage you to do that, and then I encourage you to have someone you can talk to that's outside of the health system that sees you and gives you a safe space to be able to process all of the negative feelings that may be coming up from having to navigate something like that. And then if you can at all possible, which I did, I had to seek care outside of my primary care, find someone that is reflective of your culture and your community, if possible, and see if there's support that can be offered there. And again, sorry for that experience.
Thank you, Ebony. I'm also really sorry you had that experience, Natasha. So we are at the end of our hour. I want to thank Samantha, Kalita, Ebony, thank all of you so much. And a real special thanks to Marie Hubbard at UCSF and just UCSF in general for hosting this webinar, and the CIN Center, sorry. I get a UCSF. So thank you everybody so much. And thanks for taking the time to be with us.
Yes, thanks everyone. And thank you so much, Jennifer, Ebony, Kalita, Samantha. So wonderful to have you share with the network. We're grateful for you and for all those who joined us. So thank you so much. Have a great day, everybody.
Take care, everybody. Bye-bye.